Thanks, Roger. Also, thanks to the organizer for selecting our abstract. So let me figure out how this works. Can't point, but pointing doesn't work right. Okay, so I mean, it's highlighted in red. This is the clinical. Okay. It's a clinical trial session. So why did we call this a grassroots patient-designed trial? Disclosures, we did receive some funding, but in fact, everything I'm going to show today has actually had zero funding, because actually that's why we call it a grassroots clinical trial, because all the work has been done really by these people here. I hope you can recognize one of them, at least in the autumn. We have Mark Chamul, who is our clinician, and the patient experts who have really worked on the design. I want to help a bit with the data analysis. So this is my introduction. Diagnostic biomarkers, effective therapy are urgently needed. So let's skip into the data. So we had an Paxlovid off-label use, of course. So we have now recruited up to 20 patients. Something different, we are all talking about these clinical scales. What we did is like, what actually the patients come with is having a personalized list of all the long COVID symptoms, actually from a drop-down menu, I'll show you in a minute, so that each actually patient has his individual score on a visual scale. This is, again, the work of Mark and the people there. They had an online cloud-based platform with real-time info, which also helped us to monitor adverse events. And as a primary outcome, you can see it here, we had the average drop in these personalized symptoms at 15 days. Secondary outcomes, we have these validated clinical scales, also patient-reported scales, Coop charts, I will be showing you in a minute. And of course, we try to do some transcriptomic biomarker changes as secondary outcomes. So as you can see, this is a visual scale I was talking about. So you can clearly see some examples. I can't point here, but there's fatigue, which is actually the same word in French and English. There is PEM, there is insomnia, there is brain fog. There's a lot of symptoms. As you can see, this is one patient who's actually a non-responder. See in the first line, the test, first column really, that's the baseline of the patient, fills it out on a visual scale. And green, you can see, of course, it's totally absent, goes to 6, red, which is actually the strongest possible symptom scoring. So the patient scores this every day over the 15-day treatment. As you can see in the graph there in the middle, I can't point, but you can see it nicely fluctuates around 100% of the symptoms. You can see that it still stays red and orange all over. So actually this is a non-responder. And in contrast, you can see a patient that responded very well. You can see there were fewer symptoms with lower scores, but overall you see there is some fluctuation, but you can very nicely see that from 100% at the first 2-3 days, there was a very rapid and quite persistent drop, and it goes from red, orange to green, and reaching a nadir. So again, we are using the HIV vocabulary, as many people here, a nadir of like over 80% drop in these personalized symptoms. Of course, we want to do some statistics on that. So we saw an average 1/3 drop in these total symptoms, which was quite significant. As you can see, there was strong variation. And it seems like from this graph here, that patients who had the highest symptom scores were actually doing a little bit better. But even patients with lower scores had significant decreases. So if you plot this as a mean percentage in symptoms, you can see nicely on the top, those people who are above or people actually got worse. What is pretty reassuring that none of them had increased over 10%. So if they got worse, it was really very little, whereas we saw quite spectacular decreases in these personalized symptoms. Half of the patients had at 15 days more than a 50% decrease in symptoms. And if you took the mean percentage decrease over these 15 days, it was again still over 30-40% of decrease. So this is the Coop chart that I'm talking about. This is our other secondary outcome. And as is shown on top, we didn't have a placebo, but we had a comparator group, again, leaning in the HIV field with the lecanemab trials, where we have a comparator arm. So in fact, all of the cohort had received anticoagulant prescriptions as a first-line treatment. So the first graph, can't really point there, you can see is the PAX in between. And you can see on the scores here, there are 6 dimensions in this scoop chart. And the nice thing about it is it only takes 3 minutes to fill it out. So the clinician, together with the patient, or the patient can do this remotely. It's a visual scale with the emojis. And for instance, the feelings is something I will focus about, which is actually a measure of anxiety and depression. There's also activities of daily living, which I'll come back to later. But if you get this total, and of course, the higher the number, the worse the patient is doing, you see that in fact, the patients who opted for Paxlovid were doing worse. They have over 20 in their total symptom scores, but they dropped it quite significantly over 15 days. Whereas the roughly 50 people who received only antiviral therapy, well, there was no significant decrease, strong variation, but no significant decrease after first-line anticoagulant therapy, which is, as I should point out, a double antiplatelet therapy as a flow plus clopidogrel, so it's quite active anticoagulant treatment. So secondary outcomes, there was significantly decrease in the COOP chart as well, only in the Paxlovid group, not in the first-line group. There was also significant decrease in clinician-reported severity, which was using both the LC grade and the Duke University's score of severity of illness. Sorry, thank you, Mark. Of course, we needed to do multivariable logistic regression because we heard about all these confounders we've been talking about for the last 2 days. So we did a very stringent correction for all of these confounders, as you can see in the table there. Age and sex did not confound the results, neither did the number of acute COVID episodes or the COVID waves. We also corrected for that, as we know that Alpha, Delta, Omicron have different severities. Severity itself tended to be significant, just like vaccination doses. As you can see, in the green line, there are the odds ratios. So higher odds means that there's a higher chance of getting better over time. This is a total of 110 patients in the cohort. Those that opted for anticoagulant therapy, those that opted for Paxlovid therapy, and those that stayed without treatment. As you can see here, the strongest green one, it's like an odds ratio of 10, meaning that the patients who opted for antiviral treatment had 10 times higher odds of being responders, of recovering over time. Where there was only a tendency for severity, so worse patients were actually doing it slightly bit better. And vaccination doses, each vaccination dose, in fact, rises the odds of getting better, but these were not independent predictors, neither was anticoagulant treatment. So only antiviral treatment was significant in this assay. So going to the biomarkers, and again, hitchhiking on what Roger said and what Mike has so nicely proposed, there are several flavors of biomarkers. There are diagnostic ones, the ones we're all about, maybe looking at persistence, depending on where we biopsy. We opt for the blood, but of course, there's pros and cons to all of them. We need these biomarkers to guide treatment, whether that's antiviral, anti-inflammatory, anticoagulant. And of course, we need these predictive biomarkers that can help us predict clinical evolution. So if you take a sample before treatment, that we know there's going to be a responder or not. And then, again, inspired by Mike, I believe that all of these can be, at least in part, mechanistic, and I hope to try to convince you in the last minute or so of this presentation. So this is published data, so I can go really quickly about it. We believe we have a candidate diagnostic biomarker for long COVID, which needs to be validated. So everyone out there, please help us validate this, which is based on the viral antisense RNA and one immune marker that together really nicely classifies cases and controls. So what about anxiety and depression in the COOP charts? So as I get highlighting one of these 6 dimensions, this actually, just zooming in a bit, this is answer to the question of says, during the past 2 weeks, how much have you been bothered by emotional problems such as feeling anxious or depressed? So if we quantify this, that the patient actually had very high scores, were extremely worried by anxiety or depression, or the patient had actually higher antisense RNA, so as we know, a surrogate marker of viral replication. So we wanted also to look at that more specifically in this Grassroots trial. So just very briefly, this is very recent data. This is our first try at having predictive biomarkers. We used a pre-treatment sample, the blood sample. and we just classify all of the genes and all of the markers in the order of better response. So as you can see here in the red, patients that are actually doing worse after Paxlovid treatment. You can see here in these, oops. Yeah, so these orange-like colored genes, I don't know if you can recognize the colors. This is like CPA3, which is a bona fide mast cell precursor gene. GATA2, the IL-3 receptor, and then especially would like to point out the one in the middle, which is called HDC, histidine decarboxylase, which is actually the enzyme that produces histamine and of course causes all these very typical mast cell reactions. So patients with higher levels of these genes actually had a worse outcome. However, there were no classical mast cell genes, so we do think these are precursors, not bona fide mast cells, which are usually absent from the blood. Okay, I'll skip to these other ones and just go to my last conclusion slide. We believe that there might be some unifying interpretation here. So these higher mast cell precursors, of course, linked to mast cell activation syndrome. Feeling anxious is, of course, linked to what Professor Antonio presented to us yesterday. So anxiety is linked to tachycardia, which is then linked to POTS. And then, as we saw, the protective effects, either the genetic effects or a PCR positive diagnosis, can be directly linked to the viral persistence of the reservoir. So I'll quickly conclude. So we try to believe that we've learned from this Grassroots trial that personalized clinical scores can be more sensitive. We think combination therapy would be the way to go, anticoagulants, antivirals, anti-inflammatory, etc. And we do believe that digital transcriptomics can also teach us something about viral persistence, either as a long COVID diagnostic biomarker or as a possible biomarker for anxiety and depression, which we believe might be linked to mast cell precursors in the blood. Of course, we need to validate this in larger trials and larger cohorts. Then quickly acknowledge actually people who are strongly involved in this work, Mark Jamoul, our clinician, the patients, the people from the lab and our colleagues abroad for the collaboration. Thank you.